to find a problem in healthcare. In this case, it's triage and triage accuracy. Can you build a machine learning model that can make decisions as well or better than an emergency nurse?
Hey everybody, this is Kevin McFarland. On today's episode of The Art of Emergency Nursing, I'm excited to share with you an interview I did with my friend Deena Brecher. You may know Deena Brecher from her work with the Emergency Nursing Association, but what you may not know is that she's working with a startup that wants to be the little angel over your shoulder while you triage. I'm excited to share this episode with you. You're going to love it. Enjoy this episode with my friend Deena Brecher. Well, just for the folks who may not know you, I'll let you introduce yourself, tell them a little bit about you, a little bit about what you do.
So I'm Deena Brecher. I've been an emergency nurse for 22 years. My passion has been peds and patient safety. And when I went to grad school because I never wanted any bedside nurse to feel frustrated that they couldn't make a difference, which is why I became a clinical nurse specialist. And that's really been, my goal in life is to help nurses be the best that they can be. So in my role now as the clinical implementation and project management lead for a company called Mednition, it is, trust me, it is. That's because I have like 7 jobs. That's what happens when you work for a startup.
That's right.
I get to do that on a completely different scale. I get to support ED nurses in their decision making at triage and along the rest of the continuum of the ED visit, because we all have time pressures, we all have biases we bring to triage, and this is a way to kind of tap you on the shoulder and say, hey, you might want to look at this again.
So what does the software do?
So the company I work for, called Mednition, we use artificial intelligence and the ability to read and understand every word in the medical record, including free text, to generate clinical decision support. The company started because one of our co-founders, Steve, his daughter, Kate, was the victim of multiple medical errors in the emergency department when she was 9 years old. She's fine today, but Steve, coming from the background that he comes from and doing a lot of project management and performance improvement and software engineering, he wanted to make a difference. He wanted to see how he could help the hospital do better. And so when he went to see the CEO said, I hired the best people I possibly can. Everybody does the best job they can, but this is healthcare and these mistakes are going to happen. And that wasn't good enough for Steve, nor his brother Christian.
That's a hard answer to give.
It is,
and it's not wrong. It's not wrong, maybe, but it's, certainly mistakes happen, but that's not the answer any father wants to hear when we're talking about your daughter's life.
Exactly. And when you have the ability and the skill set to help make a difference. Yeah. And so that was 9 years ago. And Steve and his brother Christian set out to figure out a way to give clinicians the information they need to make the best decision possible in the moment they need to make the decision. And that's how Mednition was born. And from a machine learning perspective, is it possible to find a problem in healthcare? In this case, it's triage and triage accuracy. Can you build a machine learning model that can make decisions as well or better than an emergency nurse?
Wow, that's is this going to put us out of work?
Absolutely not. Absolutely not, because your assessment skills are the most important piece of the picture, right?
Yeah.
So you need to be able to assess your patient. You need to be able to document your assessment. What we do is we provide that second set of eyes, that opportunity to say, hey, you know what? Did you notice that systolic blood pressure you typed was 70 and you really meant to put that in the heart rate box? Or did you notice the patient's heart rate was really 138 and you made the patient a 3? Maybe we want to reconsider that. But the ultimate decision-making will always belong to the nurse that has the patient in front of them.
Nice. Nice. Because there's times when you're going, yeah, okay, I know the vitals sound really bad on paper, but for this child in this particular case with these particular set of problems, probably not a big deal. So,
and if that were true all the time, I wouldn't have a job.
Yeah, but the problem is it's not always true.
Correct. And we're not really good at picking out when it is and when it's not.
Yeah.
And so that's why machine learning can really help us, because when you look at big data and you look at all of the information that is actually available to you at the time you do your triage assessment, which we don't have time to go and read, by the way, but there's a lot of stuff there. We don't see the patterns. It's beyond the capability of a human to see those patterns in hundreds of thousands of patients. Yeah. But machine learning, you can see those. And so Kate is our machine learning model for triage, and Kate sees those patterns and only sends you a message if there's something that potentially this particular patient might be sicker than you think, or we can message the other way that this patient's not as sick as you think. And it really is kind of like the wisdom of 10,000 experienced emergency nurses on your shoulder and 200,000 patient visits, and all of it working together to be able to provide you the best information possible. You think about Reason's Swiss cheese theory of why mistakes happen. You have the block of Swiss cheese and you take a pencil and you try to stick the pencil through the Swiss cheese, but you put it in the hole and there's cheese behind it. Yeah. So mistakes happen when all those holes line up. And so if you think of Kate as a piece of cheese trying to help prevent a mistake from getting to the patient.
Makes sense.
Yeah.
So how does it work? So it reads your triage note?
So because we read and understand free text, which is the part as an ED director, I wish I had that when I was an ED director. My life would have been so much easier.
Right.
We take everything that you enter, your assessment information, any historical information, whatever you put in your triage note, plus any historical information, medical history, social history, surgical history that's already in the record. When you sign your note, we get all of that information. We have to clean it up because we don't really pay attention to spelling and grammar when we're typing as fast as humanly possible.
Yeah.
And so in order for the machine to read and understand that, we actually have to correct errors.
Be like, right. Yeah.
Correct. And then we make a prediction. If Kate disagrees with the nurse, then a message goes back to the nurse. And that all happens, it takes about 5 seconds from the time the nurse signs their note electronically until the time they get a message.
So the patient will likely still be in front of you.
That's the goal, right? Because if you get that 10 minutes later, then it's not really useful.
Yeah. If you get it 10 minutes later and they're already back in the waiting room or not.
Or you're triaging the next patient.
Yeah. You're like, okay, I'm on someone else now. Thanks, Kate. We're good.
Exactly.
But it's going to happen in real time. So in real time, it's going to look at your note, look at the history, look at all the data that you've put in there, and then try to come up with an ESI level as well?
Correct. So we'll make a prediction about, so we'll take your ESI level, the triage nurse's ESI assignment as well. All of that information gets run through the model, and then the model makes a prediction about the ESI for that patient. And when there's a disagreement, we'll send a message back to the nurse.
Wow. That's in real time.
In real time. Yeah.
That's really cool. That's like
really cool.
That's like having a very experienced ER nurse looking over your shoulder going, maybe not.
Exactly. And it's all meant to help us learn. We learn best as adults in real time, in real life situations. And so those messages are like little educational opportunities.
Right. Does it say why? Like
in some instances it will.
If Kate says this is a 2 and I'm saying this is a 4, what is it going to say? What did you miss?
So in certain high risk situations we will. And so we'll send a message that says possible sepsis because the patient has a source of infection and 2 SIRS vital signs. We might say possible stroke. It depends on the situation, but yes, we try to send rationale whenever we can. in high risk in 2-3 ESI 2-3 or ESI 1-2 situations. So we'll say your MAP's less than 60, the patient's tachycardic. Because again, it's that learning. It's what is it, and we're all why people. So you got to tell me why you're giving me this information. And it was a request actually from the nurses at Adventist Health White Memorial in the emergency department for that why, because when we first started last December, we didn't have the why, but we quickly added it, and it really made a difference.
It was just, hey, this is a 2, not a 3.
Correct. Here's your vitals, here's your note. Yep, exactly.
Wow. What a powerful potential tool to make sure you're getting it right.
Exactly. And as humans, we're not perfect.
No, of course.
And we make mistakes all the time. And Kate's not perfect either. Kate constantly learns. And so the more feedback that we get, the more we can train the model and the better the predictions get. And so we continue to update Kate about every 2 months, sometimes sooner than that, to help that learning process continue. Because really our goal is to have Kate as close to perfect as possible and have the nurses right there with Kate.
Yeah.
And so it's an ongoing commitment to making sure that the team has what they need to make the best decisions, and that we continue to learn just like the triage nurses are learning with every message.
That's really exciting. What an exciting thing. Holy cow.
It's like pinch me.
Yeah.
I get to do this. And Kate is awesome. But in order to have Kate, we had to create this whole platform that allows us to do all kinds of really cool things. We can de-identify large data sets. So you can do research on your data. But the coolest part is I can give you back every piece of information you enter into the medical record, including all your free text. So if you're right now doing chart audits for sepsis, and you're looking for the time in which we noted that the patient possibly had or did have sepsis, most of the time there's a box you have to click in order for that patient to show up on that report.
Yeah.
With our platform, you don't need to do that anymore. As long as it's documented somewhere, we can find it, we can understand it, we know what it means, and we can generate a report that has all those patients. And then any time stamps, and you could look for, if I wanted to look for patients between 40 and 50 years of age who came into the ER between 5 p.m. and midnight, who had heart rates greater than 120, who ended up getting admitted to the ICU for sepsis. You could run that query from your desk in about 30 seconds.
That's horribly specific, and that is like incredibly, horribly is not the right word, incredibly specific. And like, holy cow, talk about the research possibilities there and the QI possibilities there.
Absolutely.
I mean, this is how we make people better.
Exactly. It's to take the clinicians out of doing manual chart audits and provide the information they need to be able to make care better.
Holy cow.
And I know I pinch myself all the time because it's funny because 3 years ago when it was actually an ENA connection that got me hooked up with Mednition. But when I talked to Steve and Christian the first time and they told me what they wanted to do, be able to read and understand and report off of free text, I laughed.
Yeah, you're like, you can't do that.
I was like, 3 EMRs, almost 11 years as a clinical nurse specialist, 2 years as an ED director. It can't be done. Yeah. And they looked at me and said, yeah, we're doing it. And they were so confident about it. And I thought, you know what, if they can do it, the way we improve care is going to change drastically.
Yeah.
So I said, you know what, I have nothing to lose. And this is really, really awesome. So yeah, I'd be happy to join and help and see what we can do. And it's just been amazing to me, the resources from a data perspective that we can give back to a team to be able to work on making care better.
What an I'm blown away. I'm blown away at the possibility of this. Now, you mentioned a couple questions that I had, like
Mhm.
EMRs. Is it EMR specific?
No, we're EMR agnostic.
Okay.
Because there's a common language that all the EMRs are supposed to be outputting information as HL7. And so there's no software to install, there's no additional screens. Part of being a company that is for clinicians by clinicians, and every decision we make has to have clinical input, because we won't put anything out that's not clinically accurate.
Wow.
But in the same time, nobody wanted another screen in front of them. Nobody
No.
wanted to wait 5 minutes to get a message. And knowing the challenges of implementing IT in a hospital setting, we didn't want that either. We wanted it to be as easy as possible. We wanted people not to have to change their workflow. We just wanted it to work and only message when you needed to get a message. And
Bless
so,
your heart.
so we
Bless
went with
you.
software as a service. So we're cloud-based, HIPAA compliant, and we take the message from whatever interface you happen to be using to send, like hospitals will send billing data to the insurance companies. There's all kinds of interfaces behind the scenes outside of whatever EMR you're working in.
I
We'll use whatever.
Interesting. I remember as a trauma coordinator, I was a trauma coordinator at one point in my career, and I remember just trying to get the trauma data collection, and it was always a nightmare. It was always, and they were another one that was software as a service, but it never worked right.
Yeah. And again, it has to be accurate for us to do anything with it. And so that has been very much our mission in life, is that it's why it took 7 years to get to market, because it had to be right. And in order to be right, we had to review cases and do all kinds of labeling and things. And so as a trauma program manager, imagine being able to come in your office every morning and review the cases from last night. And then if you wanted to look at how many patients actually fell off an ATV.
Oh, it's
you could in a second you can pull that up, and you can also look at how many of them got admitted, how many of them got discharged, how many of them had documented abrasions in the physician note or in the nurse's note.
Now, one of the things, so that brings up a question I have for you is, so this is a triage service per se, but does it monitor the electronic medical record all throughout the visit?
So great question. So Kate, the first product, is a triage decision-making machine learning product.
Okay.
But our platform can consume the entire record. We can consume the entire ED record. We can consume all of the inpatient information and make it and put it in a way that's reportable for you to search in any way you can possibly imagine.
I mean, what a powerful thing to be able to say, hey, we had X thousand chest pains and 90% of them get admitted, or to be able to go to the nurses and say, hey guys, if they have a low blood pressure, high heart rate, and a fever, 99.6% of these people are getting admitted.
Yep. And the other thing that we can do is we can actually measure practice changes before you implement them.
What do you mean?
So, at one of our beta sites, they were asked to change their sepsis screening criteria to include sore throat as a source of infection.
Interesting.
Now, if I came to any ED leadership team and said, hey, I want you to add sore throat as a source of infection for possible sepsis screening,
they're like, okay,
what's the response to that?
90% of your people are going to now have a positive sepsis screen.
Exactly.
That's false.
Well, and that's the thing, we make decisions, especially as a leadership team, we make decisions based on what we think the data shows, because we don't have access to really know what's going on.
We don't really know, but we think
because we're experienced and we think. So what we were able to do is we were able to take their current screening, we added sore throat to it, we reran 6 months worth of predictions, and we're able to come back and say, in the last 6 months, if you had been screening with sore throat, you would have had 40 additional patients screen positive in 6 months.
And as a leader, I'll say, 40 additional, that's nothing.
That's nothing.
in 6
That's
months.
nothing.
Like
That's not a workflow change.
that's not a
Yeah.
workflow change. That's not going to break because I remember as a leader talking about changing sepsis criterion and the doctors howling from the rafters saying everybody's going to be marked as sepsis. And I was like, I don't know if that's the case.
Right. And the only way to try that is to audit charts. And you
Yeah.
can't even figure out which charts to start with because
Yeah.
you don't really have access to that. The best part about that is that analysis took us less than 5 minutes.
Holy cow.
So we can test protocol changes. We can test screenings. We can help the teams make better decisions about whether or not to change something. Immunizations is something that came up when I was the director of the ED at Cincinnati Children's. There was a project that was to immunize kids when they were in the emergency department. And the thought was, that's going to slow us down completely. And so for a lot of reasons, we didn't move forward with that project in the ED. But I think about it now and I think, man, if I was able to, in minutes, look at 2 years worth of data and see how many under-immunized kids
how many you'd
came
actually
in.
Vaccinate.
Correct. And then have okay, this is what it's going to look like. Let's plan for this.
Yeah, because I'm sure without that, your nurses were like, oh my God, we're going to be vaccinating everybody. We can't do that. It's overwhelming.
Yeah. Mm-hmm.
And then you're like,
exactly.
No, it's going to be like 20.
Right.
So,
yeah.
Wow.
It changes where you focus. It changes your priorities. Having access to the data in a way that's meaningful and helpful just allows us to really focus on, okay, where are our gaps and how can we close them? And then are the interventions that we're doing making a difference? And very quickly be able to have that information.
Holy cow, what an incredible software. Oh my gosh, it's going to be a game changer. It's going to be a game changer for hospitals that implement. Holy cow. Mm-hmm. This could be the difference between, now what do you think is more commonly the case? And I've had this discussion with folks before. What do you think is more commonly the case and which is the bigger problem? Do we under triage or do we over triage? What have you seen in the data at the hospitals you've been in so far?
So when you look at the evidence, when you're looking at accuracy of acuity assignment, when you're actually in triage, it's between 59 and 65%, which we actually were able to validate based on our study data as well. And our study right now is under peer review, so I can't share a whole lot about it.
So 60% of the time we're getting it right?
60, yeah. And that's overall, not everybody is there. And, so how important is it to get it right from the beginning? I'll give you some examples. We looked at patients who actually had a diagnosis of sepsis, who came into the emergency department and were under triaged, right? Okay. And so in that population of patients, being under triage means they got a message from Kate. For the patients that they up triaged to an ESI 2 or an ESI 1, those patients had an hour and 17-minute decreased ED length of stay. We took that same population and we pulled out the patients that went to the ICU for severe sepsis or septic shock. And when the nurse got a message and changed those patients' acuities, their ED length of stay decreased by 2 hours and 14 minutes. Now, I can't tell you yet because we're still working on getting the additional data that those patients got their antibiotics faster, or they had shorter hospital inpatient lengths of stay, or any of those other outcomes we want to look at. But when you think about the sooner you get in, the sooner you get seen, the sooner you get your treatment started, the sooner we recognize sepsis, the better.
Yeah, I mean, I of course, having not looked at that data even a second, I could make the assumption that if they're getting up to the unit 2 hours faster, that they're probably getting their antibiotics at least that much faster also.
That's what we hypothesize, and we're working on, demonstrating that at this point. So it's when you have, working for a startup is a whole different experience. It's awesome. It's like exciting. Your skills increase in areas that you didn't even know existed in the world for you to learn new skills.
I'm sure.
But when you come into, you're coming into a new hospital system and you're saying, hey, we got $10 million right before the ENA conference to be able to bring Kate to the wider market, to bring our platform to the wider market. It takes being up for a long period of time to be able to demonstrate the outcomes that we all want to see. At the same time, the qualitative things that I could sit here and give you story after story of how Kate has made a difference, how I get messages from the ED triage nurses to say, hey, Kate caught this. I missed it. Kate caught it. It's pretty awesome. Documentation's gotten better. Critical reasoning's gotten better. Vital sign errors have decreased because they're getting fixed at triage instead of once the patient's in the back, they're ready to be discharged, and the ED provider, the physician's looking for the nurse to take another set of vital signs because had a 20 heart rate documented and a 87 respiratory rate documented. They're getting corrected
maybe
as we go. Yeah. So it's all it's a risk, right? To walk in somewhere and say, hey, this is really awesome, but to see the benefits and see the potential and see how we can just completely change healthcare, because we can actually look at huge data sets and figure out if what we're doing is really the right thing. I mean, emergency medicine is one of those things where, and go all the way back to EMS, right? We do stuff because we think it's the right thing to do, and then we study it.
Yep.
And
always.
So to be able to, to
be able to say, now we can study it a little bit, get some numbers, and have something to go on.
Yeah. And then change something and then reassess. Yeah.
I'm thinking of my favorite ER nurse researcher going, oh yes. Oh, yes.
Yep. Yeah. And that's really, at ENA, everybody was really excited about Kate and the support in triage, because the reality is, while we used to have nurses in the ED for 25, 30 years, we have nurses doing triage that have 1 or 2 years of experience.
That was one of the things that I was kind of thinking is, when I was a brand new nurse, you didn't even think about going up in triage until you had a few years of experience under your belt. And now in some EDs, we're sending people who aren't very experienced out to triage. And if, they have a little Deena on their shoulder going, hey, that's not good.
Right. Or take another look. Yeah. That's the goal. They feel supported, and that's what we're trying to achieve. And so at ENA, that was the excitement was, oh my God, it's like having an expert with me all the time, even though you're not, the expert's not physically there.
Yeah.
At ACEP, it was, you can give us back our data, really? And so it's seeing all of the potential for the technology that not only we develop, but we continue to work to make it as clinically accurate as possible. It's just, it blows my mind. Like, no wonder I don't sleep a lot, because my brain just spins constantly with all of the implications and opportunities to use this information.
So you guys, I remember seeing the press release around the time of ENA. Is that when you guys kind of launched to the world, said, hey, guess what we're doing?
Exactly what we did. So we launched to the world right before ENA. We announced our funding. We're one of the half of our $10 million, or $5 million comes from the American Hospital Association Innovation Fund. And and so, they invest in technology that is really game changing for healthcare. And so we're grateful to have their support as we go through this journey. But now it's like, okay, game on. We're building our team. Obviously in a startup, we're all doing a whole bunch of different things. And then as we grow, as we get more clients, we just keep adding to the team.
How cool is, I just can't even imagine being in the startup of something so exciting. How incredibly cool is that? Oh my gosh. I'm so jealous of you. You just have the coolest job. That's so cool.
I do have the coolest job. I absolutely do. And people ask about ENA and what it means, and what kind of an impact could it have on your life? Well, honestly, I ended up at Mednition because of ENA. I spoke at annual conference, and I can't remember if it was 2009 or 2010, and a woman from a consulting company who did a conference every year called me and said, "Hey, could you come speak at our conference in Vegas? You can do exactly what the same presentations you gave at ENA." And so I went, and there I met Dr. Kevin Clower, and I was one of the most amazing emergency physicians I've ever met in my life for a whole bunch of reasons. But I went back to that conference, I think 3 times. So I saw him. And then when I was ENA president, Kevin happened to be Speaker of the House at ASAP. And there was a resolution that year that ENA felt very strongly that we address in their council meeting, which is very much like General Assembly.
Yeah.
And so Alex Rosenow was the president of ASAP. And so Alex, Kevin, and myself, we worked through how we would have that conversation. So 3 years ago, when Kevin Clower called me out of the blue and said, "Hey, I've been working with these guys, and since I met them, I just thought this was right up your alley. Would you talk to them and let me know what you think?" That wouldn't have happened without ENA.
That's cool.
Mm-hmm.
That's really cool. How exciting. So how many hospitals are you guys in right now?
So right now we're in one, Adventist Health White Memorial. That was part of, in order to get funding, we had to demonstrate that Kate worked, and that that the nurses were learning, and all of the things that we've been able to demonstrate. And that was the impetus for getting our funding. Now that we have funding, we're out following up on leads from ENA, following up on leads for ASAP. We've got a lot of interest, a whole lot of interest, which is why we're building our team a little earlier than we expected.
Yeah, you're like scrambling, going, "Hey, we need people."
It's not scrambling, because it's we're looking for
the right people.
And the most amazing, there's so many amazing things about the team I work with now, but in reality, it doesn't matter what their role is. If they're an engineer, if they're a data scientist, if they're doing QA work, or they are doing clinical work. Everybody's in it for the same reason, which is to support clinicians to make the best decision possible. And you can ask anybody on our team, and that's what they're going to say.
That's
and so
awesome.
It's a really mission-driven team of I am in awe of how smart all these people are that I work with, to help us, to really help make clinical care safer. And that is probably the best part of my job. So we're not scrambling, we're trying to find like-minded people, or we are finding like-minded people who are vested in making a difference.
How exciting.
And that's really exciting.
Holy cow, how exciting. That's cool. So is there a significant cost to the hospital who's going to adopt Kate and bring the system in?
No, actually, we priced Kate to fit in an ED budget. It's not a capital expense.
Really?
Because again, our goal is to help.
Yeah.
And so, obviously we have other products and things that are at a different price point, but Kate and doing that support is priced so that it would fit any ED budget. It's a per patient cost.
Wow.
Yeah. Again, because
cool.
You've got to be able to use it if it's
yeah.
if it's $1 million a year, it's not gonna get
$1 million a year. It's gonna be like the coolest thing that nobody uses.
Exactly. Exactly. We want to get Kate out there and help nurses make a difference.
That's cool. Yeah, that's incredible. I'm so excited for what you guys are doing. I can't wait to see this in every hospital. I just can't wait. This is so exciting. Holy cow.
We're excited too. We're really excited.
I can't even imagine how exciting to be able to share this and kind of launch this right around ENA when, you're there with, 4,000 people who think just like you.
And the first off, it couldn't have happened in a better place, right? Because it to get that feedback that this was valuable, was incredible. And then we had about 10 nurses from White Memorial at ENA, and they all came to our booth, and to hear them, they took over the booth at one point, and we just kind of stood back and they talked to people about what it's like to have Kate, how it's helped them, the difference that it's making. And it was, it was really gratifying to know, okay, we don't do really well as ED nurses when someone comes and says, you did something wrong.
Yeah.
And that's not the intent of the Kate message, but that's very easily how we can take that information.
Yeah.
And so, to be able to have peers having conversations about, I get these messages and I like getting these messages because it helps me be a better ED nurse.
That's cool.
That's really cool.
How exciting. Holy cow. I'm just so I'm going to definitely follow you guys for sure and see how this goes, because this is cool. I can't wait to see this.
Awesome. Well, we're excited to have the opportunity to really work and make a difference, and that's what we're all here for.
Holy cow. Get it out here to Texas. I'd love to see it.
We'll come show you anytime.
So that's really, really cool. So I'm blown away. I've always been a big fan of you. I think you're incredible. I think you do such cool things, and I'm super jealous of what you're doing because it's cool. So
it's cool. Well, thank you. It all, you think about where you thought you'd be in your career, and this wasn't even like
not even on your radar.
No, not even in the universe, right? But when you, and I think it's true, when you follow your passion, and you're really solid in what you're trying to achieve, it's amazing the opportunities that present themselves.
Yeah. And when you're following your passion and you're not locked into what that looks like.
Mm-hmm.
So you're saying, I want to make a difference in nurses' lives. And you're not locked in saying that means I got to be behind the desk of a hospital. Maybe it's, you're sitting at home working from home, but for a startup, that's cool. That's really cool.
And that's, in the same, it was not my dream to be ENA president. I mean, that all happened sort of by accident.
Yeah.
Once I started doing, once I got elected and to the board and started doing the work, I fell in love with doing it. And I fell in love with having the opportunity to have an impact on the profession at a much different scale than just in one emergency department.
Yeah.
And that is how I ended up becoming president. The more I did it, the more I enjoyed it, and the more passionate I became about having the opportunity to be the voice of emergency nursing. And so this is the same thing. That message is the same. It's, we all have to take responsibility for the care we provide, and we need to be willing to change what we're doing for the betterment of the patients and for the betterment of ourselves. And so that kind of passion and mission in my life has allowed me to literally jump off a cliff. I mean, I had a really, really stable, very high-paying, low-stress job before I took this leap, right? And it was, I'm going to do this because it's the right thing to do. I'm going to learn a whole bunch of new things, and to be able to be part of this is amazing. And if in a year the ride's over for whatever reason, I won't have regretted it for a second.
Yeah, that's cool. That's really cool. Well, I got to get you back on the podcast another time, and I want to just hear about you and your story, because you're what a cool thing you've gotten a chance to do, and I'm sure you got a million stories to tell.
I have a couple, yeah.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.